The management of refractory stage D heart failure represents the most challenging frontier in cardiology. By definition, these patients remain symptomatic despite optimal medical therapy at maximum tolerated doses and require specialized interventions. When guideline-directed medical therapy with ACE inhibitors, ARNI, beta blockers, MRA, SGLT2 inhibitors is no longer sufficient, the focus shifts to palliative or bridge to transplant stability. Inotropes, use of tailored therapy with milrinone or dobutamine. While milrinone is often preferred in the setting of pulmonary hypertension due to its vasodilatory properties, it requires careful monitoring of renal function. Diuretic resistance, often managed with a sequential nephron blockade strategy, adding metolazone or chlorothiazide to high-dose loop diuretics. LVEDP and PCWP management. In refractory cases, maintaining a pulmonary capillary wedge pressure less than 15 mm of mercury and a cardiac index more than 2.2 liter per minute per meter squared body surface area becomes the primary hemodynamic goal. For patients who are candidates for more than medical management, you can consider LVAD, left ventricular assist device. As in trials like Momentum 3, the HeartMate 3 has significantly improved outcomes, reducing the incidence of pump thrombosis and stroke compared to older axial flow pumps. Orthotopic heart transplant, still the gold standard for those who meet the rigorous selection criteria. Mitra clip, TEER. Based on the COAP trial, transcatheter edge-to-edge repair is a viable option for refractory patients with grade 3 to 4 secondary mitral regurgitation. In stage D, the conversation often transitions from prolonging life to optimizing the remainder of life. Deactivation of ICDs, a critical but often overlooked discussion to prevent painful, unnecessary shocks in the final stages. Ultrafiltration is considered for patients with volume overload refractory to high-dose diuretics, though the CAROS-HF trial suggested it might not be superior to stepped pharmacotherapy regarding renal function preservation. Here are a few clinical considerations. Cardiorenal syndrome. Type 1 or type 2 cardiorenal syndrome often limits the use of ARNI and ACE inhibitors in stage D. Cardiac cachexia, a profound prognostic indicator of end-stage metabolic failure. Right ventricular failure, often the Achilles heel for LVAD candidacy. High CVP by PCWP ratios and low pulmonary artery pulsatility index are red flags.